Okay, everybody, welcome to MMI. We'll go ahead and get started. I know you guys are waiting for plates. I believe they're coming. So you have to suffer through me for the beginning. We're going to talk about the echo elements of endocarditis. Then Dr. Al-Mallah is going to show you a sequence of increasingly blurry pictures for CT and nuclear and PET and a bunch of other stuff. But that's a lot of the new stuff in endocarditis is stuff that I won't be talking about. So we have to give Dr. Al-Mallah enough time to do that and get me to clinic by 1. So we're going to get started. Okay, so first question in a discussion of endocarditis is the prototypic lesion, which is a vegetation, and what does that really mean? What is a veggie? So to sort of answer that, we'll talk about both its imaging characteristics and then some of the histology and the pathologic characteristics. So this image here, and I'm just thankful it plays, demonstrates most of the hallmark features of a vegetation. So yes, there's mobility. Note that it's on the flow surface of the valve. So on the mitral valve, it's on the atrial side. Typically on the aortic valve, it's on the ventricular side. That is not a law, but it's a common feature that flow surface is the one that has the attachment of the vegetation. It has, if you look closely, a characteristic of independent mobility or oscillation. So that basically means that it's not moving synchronously with the valve or the cardiac cycle. It has kind of a little, almost like a flag in the wind effect, which is oscillation. So most malignancies don't necessarily do that. Again, there aren't hard criteria that you can always bank on, but if you sort of, like a lot of what we do in the quantitation of regurgitant lesions is sort of increasingly build your data. You want to see a veggie on the flow surface. You want it to be oscillating. And often it'll present, as this one does, some heterogeneity in the shape. So you've got a little thin element at one point. You've got a bulky element at the other point. You know, would I bet a lot of money that this isn't anything but a vegetation? No, but I bet a small amount of money. So that's kind of the hallmarks of the clinical imaging characteristics of a vegetation. Keep moving. So this is another one. So this is a different valve. This is the tricuspid valve. And again, you see it's on the flow surface of the tricuspid valve. So in this view, the flow is going up. So the image is on the flow surface, independent oscillation. Okay, and that's an IV drug user case. So this is sort of a graphic, and I do want to remind the fellows, you know, ACSAP, you all have that free access to, actually I think everybody in the room has free institutional access to American College of Cardiology Self-Assessment Program, online data resources. There's a specific subgroup of that called ECHOSAP. Within the ACSAP chapters of endocarditis, I've written a bunch of them, and we recently had Chamsi Pasha joined as the lead author, so that's available. A lot of these cases are actually from that book chapter, gives a ton of references and covers a lot of this in more detail. And Chamsi Pasha has added a lot of the newest CT data to that chapter. So that's, I'm not going to go to that chapter today, but it's available for all of you, so I sort of refer you to it. So typically, bacteria, now remember that in an endocarditis lesion, it isn't the vegetation alone that's the only problem. So this graphic is important to show that there can be infection on a broader region, as you see in this image, than just the point of the vegetation. So this is generally how it happens. You have endothelial disruption. So that simple box at the top, the endothelial disruption, sort of explains the risks associated, or the risk features of those who get endocarditis. So if you have a very smooth, uninterrupted endocardium, it's relatively impermeable to bacteria. Sort of like, you know, shark skin or the fancy Olympic swimmers that wear these suits and they sort of glide through the water. So you get very laminar flow against a smooth surface. Bacteria have a hard time taking hold. Once you introduce turbulence, a non-laminar flow, whether it's a native valve problem, whether it's a congenital defect, or if it's prosthetic material that never has the laminar flow features of native normal tissue, that's why you have this endothelial disruption. So that's a very important first problem, and that's the cascade from the top. So you disrupt the smoothness of the endothelium, then you get a reaction of inflammation, Then you get fibrin deposition, you get your bacterial attachment, and then that cycle sort of grows. So you start with basically an inoculation, and then you grow a lesion. And then depending on the bacteria, the lesion might just grow relatively benignly and become a big vegetation like a nocardia, or it could grow just a little bit and become very, very invasive and destroy all the neighboring tissues like a Staph aureus. So recognize that native, normal intracardiac structures, it's pretty hard to get endocarditis. But a significant abnormal flow, that's your biggest risk factor for endocarditis. This is what a typical bacterial inflammation lesion looks like. So you've got a combination of fibrin, platelets, and the blue stuff here is the bacterial colony. So now remember that one because that changes when I show you a non-infectious endocarditis lesion in a minute. So there's a few basic rules we've discussed for recognizing a vegetation. And whenever there are rules, there are rule breakers. So look at this one here. If you look at that anterior mitral leaflet, it looks a bit like a tomahawk. And the posterior leaflet here is also abnormal. Is there oscillation? Not clearly, I would say. Is this stuff on the flow surface? Probably, yeah. It looks like it's mostly on the atrial side of the mitral valve. And what is this? This is the one that doesn't like to follow the rules, and this is fungus. So fungal endocarditis can do a lot of different things. Depending on the fungus, it can be very invasive and disruptive. It can be slow growing. It's obviously, doesn't culture easily, and is more prevalent after prosthetic material has been implanted. So we always remember to think about fungal endocarditis when things don't look normal or they don't follow the rules. So this is a tricuspid valve, massive amount of stuff on here. And at first blush, you would think it's too big to be a vegetation. It must be a thrombus or some ugly malignancy. But once you have prosthetic material, again, those sort of rough rules about size and how big something can really grow don't exist. So this is a pacer wire all the way through, and this is a large Staph aureus collection adherent to a pacer lead. And simply, remove the pacer lead, and that problem solved. So thankfully, there was not contagion onto the tricuspid valve. So simply remove the pacer lead with some trepidation. Hopefully, you didn't have a big embolic event, and that patient did fine. So huge lesions occasionally can be found on prosthetic material. This is one that's a little more subtle. This is the pulmonic valve. We're sort of used to not seeing the pulmonic valve very clearly sometimes, so you can sort of glance over it sometimes. But, and I think some would be forgiven for not recognizing this long linear lesion on this pulmonic valve, except when you add the color and you see that there's a wide open PI, and that should, give you a pause, and then you go back and think, why is there wide open PI? And then you sort of look closely at that lesion and see that this patient had a very, very large Staph aureus vegetation on their pulmonic valve that was several centimeters in length. Okay, so just a slide or two about non-infectious endocarditis, because you do have to be thinking about that. That's not as much a diagnostic, differential, an imaging differential, but as a clinician, you certainly have to be recognizing this entity. So this is an example. And you see here, you see the mitral valve. We focus your attention here. And it doesn't quite follow the rules we've already discussed. It's a little bit on the flow surface. Looks like there's some diffuse thickening on both leaflets on the ventricular surface. There isn't clearly oscillation, but it does look abnormal. You might just call that thickening. But I think if you looked in detail and you can see, it shows up better on this view than it does on this view. And I'm not sure how well it projects up there, but there is a little small mobile element right on the tip at the coaptation point. So this is an example of a Libman-Sachs endocarditis. And that's, oops, that went too fast. Get that back. And that's kind of what they look like on histology. They tend to cluster all around the coaptation zone. This can occur actually on structurally normal valves, so this is not following the standard rules that you require endothelial disruption. And that's kind of what that looks like. And that's sort of, we know, associated with SLE. So the common complications. So in the imaging lab, this is often where we're involved and what are the things we're looking for. So if you look at this one, you see here, focus at the base of the posterior mitral leaflet. It's not present in every view. There's this little chunker that kind of flicks in and out of view. That's a little underwhelming. It's like, well, maybe that's something, maybe it's not. Let's put an explant across it. Let's find some more views. Let's really decide if that's a real thing or not. And this is not uncommon. Somebody gets sent for TE for, recurrent fever and not much else, and a transthoracic was pretty benign, except for a little MR that nobody could explain. And then you put the color on, and you see this. So this is a proximal flow convergence, a vena contracta, a distal jet, but it's not coming through the coaptation point. So this now we have the association of endocarditis. So we had a funky lesion here that was suspicious. Now we have basically a perforation in the region of the funky lesion. That's endocarditis. Okay, and there it is in a still shot with an arrow to make it easier. Okay, and that's kind of what it looks like, or it can look like. That's actually an anterior leaflet, but that's sort of what happens when you resect these things. They're never normal. It's never like a hole punch through the lesion. There's always this sort of heaped up inflammatory reaction, and you can see that. It looks like a son of a mini volcano all the way around, and that's really a windsock. So the windsock sort of gets bigger and bigger and bigger, and then it pops the tip, and that's how you get a perforation. So that's what a surgeon sees. And then they can repair these occasionally. They can just put a patch on it if you're sort of sure that the patient is now culture negative and sterile for a while. Not sure who that is, but I won't take it just yet. Okay, we'll keep going. This is sort of the worst of all things. So this is a TE. This is that same patient. So this is a perforation of the base of the posterior leaflet. Then a little further along, because you're not quite done, of course, and you're pulling the probe out, you're examining the aorta, and you find a dissection, another vegetation, and basically a mycotic aneurysm. That patient did not survive. That was too much for one patient. But we have to remember endocarditis can actually extend beyond the heart, and if it's an inflammation of the endocardium, we still call it endocarditis. All right. So the prosthetic valve realm is tough for, we have lectures just on this alone, recognizing the quantitation. The real reason that this really matters is because there's so much prosthetic material. Sometimes you get endocarditis on the prosthetic leaflets. Sometimes you get it on the sew rings. There was this concept that TAVR valves had a lower incidence of endocarditis. Probably it was just they were too new that the cases hadn't bubbled up, and now there's emerging data that it's probably equal. There's very few studies looking at small numbers, but there really isn't, as far as we know, a protective effect of a TAVR valve over a surgical valve. Some argued early that the flow hemodynamics were more laminar, more efficient, therefore less turbulent flow means less setup for bacteria, but that's really, that turbulent, non-turbulent is really a native valve phenomenon. And once you have all this prosthetic material, bugs are going to love it. So any of these can get infected. This was a case, hopefully this place, here we go. This was somebody with recurrent fever and just didn't feel well months after a surgical AVR. And this is pretty classic. You have a big shadow from the prosthesis. You can't really see. The mitral valve has some lumpy, bumpy chunks. But on color, there was no evident mitral dysfunction. There weren't any discrete lesions on the mitral valve that would make you think. But if you look just a little further up here, in the ascending aorta, there's a wiggling mass up there. So what is that? This is now several months later, culture negative mass just distal to the prosthetic valve. And that was, again, our friend the fungus. And in fact, when the surgeon went back in to open this up, there was a little suture from the aortotomy where they had to open up the aorta to do the AVR, and they closed it up again with sutures, and a tiny little piece of suture was hanging in the ascending aorta, and that was enough of a nugget for fungal to grab onto. So presumably an actually intraoperative contaminant that took 4 or 5 months to come to that size. But, it was missed on all the transthoracic imaging, evident on the TE. So we know that there's a fairly low threshold to do a TE whenever there's prosthetic material and a concern for endocarditis. This is a different one, much more obvious. This was 4 months after an AVR. This one was actually done for stenosis. So the presentation was increased gradients and dyspnea after an AVR. You can look at this and you think, well, could that be a thrombus? We've looked at a lot of thrombus on TE now, on CT. I don't know that we've ever identified one with a large mobile element like that. So this would be a high suspicion for some kind of funky bug. Interesting, there's no evident, well, there's a little bit of thickening around here. This is when it's tough, because you're 4 months out now from an AVR. Is this pathologic sort of lucency around prosthetic material, or is this the normal inflammation after surgery? 4 months, it's a little late. You do expect that within a couple of months. Maybe not the lucency, but certainly clear thickening around the periaortic tissues within the first few months of surgery is expected. That's getting beyond what's expected. This is clearly not expected. And this was no cardia. This was a huge lesion, several centimeters long, sort of tracking right up the aorta. But the patient had a good clinical outcome. So just recognizing different bugs at different times. Yeah.
Is there like any guidance or cutoff as to how much thickness for how long? Because you typically do these speeds.
Not really, because it varies by age. It varies by how much they get inflamed. It varies by probably surgical technique, if there's a lot of blood in the field or bloodless, or even probably the type of prosthetic valve. I think it's more the clinical scenario. If you see a little bit of benign thickening 2 months after procedure and no other indications for endocarditis, you're okay. I'll show you a case in a minute with the opposite. If you are suspicious of endocarditis and you see a little thickening, I wouldn't necessarily send the patient for surgery, but you bring them back quickly, for a repeat study in a couple of weeks and see if that thickening changes. And if it's changing in the right direction, you're good. If it's changing in the wrong direction and becoming thicker or more lucent, then you got to do something. And I'll have a case of that in a second. This is a patient who was sent to us for concern about endocarditis. This is a patient post-mitral valve repair. There's the ring. This is the mitral valve. This is an atypical angle I'm showing you. This is the os of the left atrial appendage. This is the concern. This very long linear wiggler. Looks like a sort of dancing snake or something. Culture is negative. A short differential for something that big. I mean, that's not a malignancy. It's highly mobile and in a weird spot for a thrombus. What the hell is this? And when you don't know what to do, you often just do serial imaging. But this was, the issue here was just open the chart. So what this patient had was an attuned surgical ring. So this is the ring in the box. Basically, the surgeon affixes it to the annulus and is supposed to use these two things to sort of tighten it up like a belt and really cinch down the annulus and throw several knots. Usually you get a little nubbin of about 10 knots deep, which looks usually at the 6 o'clock position on one of these valves on a 3D TE, this long little post of knots. In this case, the surgeon didn't tie that properly, and they sort of left this thing dangling. So it just took a little reassurance that nothing had to be done. So funky, but not endocarditis. This one's not so lucky. So this is a mechanical valve in the mitral position on a TE. This is usually what happens. It's very rare to find a lesion attached to a pyrolytic carbon or a metal element. So they don't. They tend to attach to the frame. So here you can see on X-plane this thing is coming down here, another one over here. Not hard to imagine that could actually interfere with closing or opening of the valve. So these can present more typically with stenosis. They don't usually present frozen open with wide open MR because that's a higher pressure gradient, but they'll present closed. So usually they'll present with stenosis or fever or something else. This is a surgical lesion that you really shouldn't be fixing. Tough to know, is this thrombus or vegetation? I wouldn't be able to tell you from that image alone. We'd probably get a CT, which we'll hear about in terms of the utility of that. This one is an interesting dilemma. So on a bioprosthetic valve, you do actually get vegetation on the leaflets because the leaflets are biologic material. So unlike a mechanical valve, in the bioprosthetic you do. So this shows that. This is a very weird looking bioprosthetic valve. The posts and the sew ring actually look okay. This was a patient with very high surgical risk, so a very low appetite to take him back to the OR, recognizing that this is almost impossible to sterilize, but almost a palliative approach. This patient got several weeks of antibiotics with fingers crossed and hoping for the best, not what the guidelines would suggest. And miraculously, after 6 weeks of IV antibiotics, the bulkiness is gone. So almost case report level. I think we did report it. But the valve didn't get away scot-free. So there had been changes. Now look at this leaflet. That's not normal. It goes a little concave as it comes in. So one leaflet sort of took the brunt of the inflammatory reaction here. And then on 3D, you can clearly see a few more things. So now there's these 3 paravalvular defects. All small, none of them causing heart failure, but yes, causing hemolysis. So you trade off a little bit of hemolysis for the rest of the life. and frequent transfusions. And nowadays we would consider plugging these, but not until they were demonstrated culture negative for several months. I think there's a still image here. There you go. So these are these three discrete paravalvular defects, and then you can see some of the thickening that's been acquired on these bioprosthetic leaflets. So the leaflets isn't normal. The diastolic gradient through the valve is no longer quite normal, basically scarred by endocarditis, but not fatally damaged. So weird case, but that happens from time to time. This is a different one. This was a physician referred to us. He'd had a history several years ago, 2 years ago actually, of basically a total crux rebuild in Philadelphia for endocarditis. And he was visiting Houston and collapsed, and the TE shows that the mechanical mitral valve, there's a little bit of suspicious thickening around here, but no obvious vegetations. And this over here is sort of, often sort of written off as that's the aorta, but it wasn't the aorta. That was a massive dehiscence from, basically a quarter of the circumference out to the crux. So that was not survivable. And the crux I mentioned, so this is just some important basic anatomy that is relevant to both echo and CT, of course. The crux refers to sort of the internal skeleton of the heart, or the cross. The reason being is how close together the AV valves are with the semilunar valves. And that matters when you start talking about complications and where things go. So this is an elderly gentleman, had a previous bio-AVR, now presents with fevers and chills, so a very low threshold for what to do about that. Looking at the valve in detail, it doesn't look too bad. Nothing too overly obvious here in the leaflets themselves. A little further on in the CT with X-plane, there is identified this little nubbin here. So that's unusual. So given the context, that was diagnosed as endocarditis. So it meets due criteria, has a mobile mass, has fevers and chills, culture positive. You don't see it on the short axis, but you see it on the long axis. The decision there again was made, this is, elderly-ish gentleman, can't do TAVR on this, relatively high risk or elevated risk at least for a redo AVR. Let's go antibiotics. That was the gradient at baseline. So his presentation was actually stenosis. So particularly I've never seen endocarditis cause native valve stenosis, but clearly on a bioprosthetic valve, it can happen. We've seen that several times. So markedly elevated gradients over 4 meters with symptoms. So as much to treat the stenosis, 2 months of IV antibiotics, and then a repeat. And we feel great because the lesion is gone. So all kinds of sweeping through, and there's no veggie. So we all feel pretty good. And somebody's saying no. And when you X-plane through this area here, that's really the abnormality. When you can see it beautifully here on the side as well. So it has that not just thickening, but now we're several months after surgery, and it has a central lucency in the setting of known endocarditis. This is somebody you cannot gain any ground with medical therapy. This is endocarditis requiring surgery. And in fact, if you had looked back in detail at the very first view, it was there. So this is Faisal, the case I mentioned to you. It was there at the very beginning. There was a central lucency. So the abscess was present. It was a waste of time sending this patient for 2 months of antibiotics because they needed surgery. Okay. So all of this anatomy is very important here. You got the central fibrous trigone. Oops. Let's go back one. That went too fast. Okay, so this is the mitral valve, aortic valve, tricuspid. The fibrous trigones this is the left fibrous trigone, the right fibrous trigone. The conduction tissue runs right here. So obviously new conduction abnormalities are one of the features of endocarditis, but recognizing how the mitral and aortic valve and all of this crux are intimately connected and how really you can get a fistula from the right kind of bug that's very invasive into any of these chambers. So we've seen fistula from the aortic valve to the RA, from the mitral to the aorta, from the aorta to the LA. Any of that is possible. So when you're doing the diagnostic imaging and there's a concern, that's where the sweep is incredibly important, and to get off sort of the standard views. If you sweep and you see color that usually doesn't make any sense, in this scenario, it may make sense. So that's where the focused views to sort that out are very helpful. And this is just a TE showing that sort of intimate relationship, anteromitral leaflet, posterior leaflet, aorta. And see the bulging here as the flow goes out the aorta and it moves that tissue. So the aortic mitral continuity is here, also from the underside. And that's why these intervalvular fibrosa, the aortic mitral continuity, is a critical region to evaluate both by CT, by TE, and as much as you can by transthoracic. Okay, I'm going to just show you a lesion here. And these are my last couple of slides. Oops, there we go. I get this guy to play now. So I got to go back and then forward. As soon as the laptop meets the projector, it becomes unhappy. There we go, okay. So that's another example of a root abscess. So very focal. The leaflets themselves look fine. It's very focal here, and this is native valve. That's why I'm showing you this one. So it can happen in native valve. You don't need prosthetic material. This will almost always be, if it's a native valve infection like this, you could probably bet money this is going to be Staph aureus if it's to be this invasive on a native valve. This is an even worse collection. This is aortic root abscess, sorry, an LV aneurysm and an abscess, and that same intervalvular fibrosa involvement. That one was not survivable. This is the classic root abscess, so very large, not subtle, you know, but a very different, the population of cells there is not homogeneous. So function is important. This is a nomenclature thing. So if you see it pulsing like that, if it's pulsing, it generally means it's open only at one end, okay? Because the flow pressure goes up, is contained, and pressure comes back down. So this is an example, even without the color. This is connected only at the LVOT or at the aorta, but it's not going to be connected at both if it's pulsating. So pulsatility is very important to recognize. It means a pseudoaneurysm, that's the definition. And then go forward. Okay, you add the color, you can see the pulse and the flow is back and forth through the LVOT, so that's a disruption of the intervalvular fibrosa. Then, okay, so now we have a true aneurysm, or sorry, a fistula. So now it bursts at both ends. So it's coming up from above here in the aorta, coming right around, and look how much less pulsatility there is. So the pulsatility disappears when you open up both ends. So that's a fistula. By definition, open at both ends, a pathologic communication, and this is what the surgeon finds. So down the aorta and out into a chamber where it shouldn't belong. So basically what I try to show you is it's an inflammation of the endocardium. Usually involves the valves, doesn't have to. Once you introduce prosthetic material, a lot of the rules don't apply anymore. The lesion, the vegetation is really what you have to define. Platelets, fibrin, microorganism, of course, and the inflammation. And echo is all you ever need all the time. Okay. I lied about the last part.
All right, so we're going to move to the gold standard now. All right, so I'm supposed to cover 3 modalities: CT, MR, and PET. All right, okay. So I'm supposed to cover 3 modalities, so we'll start with the one that Dr. Mamarian always calls the king. So CT is king, we'll start with that.
You don't know what's going on?
All right, so CT has, most of the time patients come to us to CT, they know that there is something going on, so they're not unknown, although we are always ready for surprises, but could not figure it out completely on the echo, so they come to CT. So if you do a dynamic CT, obviously retrospective gated, you can see that in some patient, in this patient, for example, there is a vegetation and it is mobile. And we can look also at the aortic root, look if there are any potential complications. However, if the vegetation is small and highly mobile, that might represent an issue for imaging because our temporal resolution is not as good as echo, although our CTs are the highest temporal resolution in the country. So if we can't see it, no one else can see it right now. But we can also see some other surprises also, like some of the pseudoaneurysm and the complications that you can see with the complications that we've heard about from Steve a little bit ago. So one of the things that I want to point out that small, highly mobile vegetations may not always be seen. However, if they are large and less of motion of their own, then you might be able to see them very well. This is one thing. And in terms of diagnosis of vegetation itself, there have been a study looking at CT versus other imaging modalities. So if you take TE as gold standard, CT does perform very well in terms of sensitivity, about 97%, negative predictive value 88%. If you take it against operative findings, sensitivity is comparable, and positive predictive value is 96. If you take it versus TE for vegetation size and mobility, there is good correlation. So when we can see it, we see it very well in there.
But you gotta be careful about number two, because once you go to operating, the abnormalities are so large, these numbers are over.
Yeah, but still, I mean, with sensitivity, it did not change much, but negative predictive value is about 88%. So something very important to keep in mind that if you don't see it, there's still about 12% that it's there. So it's always important to look at other imaging modalities. And that might be even a more important issue in MRI, where the images are acquired over multiple cardiac cycles and average.
But one point about the size of those things and why it's important is because if they're small, remember you have contrast in front and you have contrast in back. So if it's small, you're not going to be able to see differences in Hounsfield units.
Exactly.
And that's the reason why small vegetations aren't identified.
Can I make one more comment? Maybe we could have two microphones, I think would be great. I mean, this is, that's the beauty of this conference is we have an issue, which is endocarditis, and you're gonna have to take a look at each one of these modalities and the pro and the con. One thing that may not have been as strongly mentioned by Steve is with echocardiography, you're not only looking at the temporal resolution and the spatial resolution of the lesion. At times, you'll be surprised that there are shunts and other things that are detected by color, right? Then you go back into imaging and start to see it. And with CTA, you're not going to be able to take a look at this. Why? Because contrast is everywhere. You're not going to look at flow from one chamber to another. And at times, some of these abscesses have communication with the left atrium, with the right atrium, with few things. So color is as crucial as looking at a vegetation, particularly when things are more complicated.
And that's very true, but actually he's going to show a case right now, which is, I have the slides on this case too. We actually can see communications fairly well in terms of, we don't see flow, but we can see dehiscence and we can see leaks.
I know,
So,
but
yeah.
although CT has the highest spatial resolution, when the communication is so small that when it is small, you're not going to be able to see it.
If it's extremely small,
Exactly, you're not going to be able to see
Yeah,
it.
I mean, the only caveat, if it's a communication between left side and right side, we usually have saline on the right side, and then we can see if there is some contrast going to the other side. So,
Right, so the negative and positive contrast issues are important in terms of being able to see things, that's true.
but like for example here, you can see that there is equal contrast on both sides. So your point is well taken. We can describe anatomy, less often physiology. Although our physiology, we are inferior to echo Doppler in terms of direction of shunt and quantification, but in terms of anatomy, if you want to look at the overall picture and the overall local destruction and communication, so looking at local complications.
I want to just make one other point because, you don't do CT first as a diagnostic test. I mean, most people end up getting echocardiograms first, and then they see flow somewhere, and they may not be sure where the flow is. And then for the surgeon, CT becomes very helpful in terms of being able to accurately identify where all the problems are.
So we are not seeing every endocarditis, and I don't think every endocarditis need to get a CT for confirming the diagnosis. So if we clarify that, this is like more of a second-tier test that you need it for patients with complicated course, with unclear diagnosis, with potential complications, both local, like this patient who has like an aneurysm, or those who have fistulas, or of those who are not improving with therapy. This is another case that you have, like you can clearly see a pseudoaneurysm, but there is no communication with the other chambers. And there are other cases where you can see now here, based on looking at it, there is a communication with the aorta to the left atrial fistula. So you can see from the aorta going, there's a fistula in there. Now, I cannot tell you obviously about the direction. And obviously here you can see large pseudoaneurysm. So if it was dynamic, then you can see the pulsation of the aorta. So looking at, in terms of complications, abscess and pseudoaneurysm in this study among those patients who went for surgery, obviously. So this is a highly selected population. CT was able to 100% identify these patients who had these complications.
I just want to make one other point because, yeah, that's,
Again, this is a highly selected population.
yeah, nothing in life is 100%, right? Except for certain things, death and taxes. Anyway, which we're about to pay. So, but I do want to make one other point about this because, and I showed this at the Multi-Modality Imaging Conference and emphasized it, is that even when you don't have a pseudoaneurysm, in people who have their native aortic root, and I emphasize that because once you have prosthetic material, it's difficult. But once if you have a native aortic root, usually there's peri-aortic fat, and it's usually minus 100 Hounsfield units. If you start seeing positive numbers around the root, that is highly suggestive of a forming abscess cavity before you may even have before you have a pseudoaneurysm. And in fact, we have serial images in people who clearly had endocarditis, were treated, and then they came back a week later and actually did have a big pseudoaneurysm. So it's something that everyone should be aware of on CT when you read it, to make sure that that area around the root and around the ascending thoracic aorta has the typical negative numbers in terms of fat, because if it doesn't, that's a real concern.
So this is what Dr. Mameni is referring to. This is the fat that you see here on this side and that side. And here it's kind of absent on this side where you're starting to develop the pseudoaneurysm. All right, so now we're moving to the mechanical valve, because this is another area where echo might have some problem in terms of visualization of the mechanical valve. With CT, with our limited temporal resolution, at least we can tell you that we are open or closed, and if there's any problem with that. But often, sometimes, and this is from one of Dr. Mamerian talks, you can see that there are some lesions in there. You can see here that there is a vegetation or thrombus on this valve leaflet, which is dysfunctional. And now we have to sort out if this is truly a thrombus or a vegetation, and I'll show you in a bit how we do that by CT. But we can see some of these lesions also on bioprosthetic valves. Sometimes it's difficult to look at them also because of sometimes you have metal artifacts from the ring, but you can also get a look at the at the valve itself and its opening in these patients if you're doing retrospective gating. TAVR, we're starting to see on and off sometimes TAVR vegetations and endocarditis for these patients. And some of these that are called halt hypoattenuating lesions that you can see in here. And using the Hounsfield unit, we know that if the thrombus Hounsfield unit is less than 90, if it's spannous more than 145, and anything in between, anticoagulate and follow up again by a repeat imaging. So when you have these, it's helpful in terms of figuring out. Remember, vegetation might look like closer sometimes to a thrombus because a lot of fibrin material that looks in there. We can also look at aortic valve dehiscence. This is one of the very first cases that I've read here, where you can see this ring is moving around. You can clearly see valve dehiscence. And for prosthetic valve endocarditis, the overall sensitivity, and again, these are a couple of studies. Most of this work that I'm showing you today is done in Europe, whether in CT or in PET. They have been kind of leading the field in terms of the role of CT and PET in endocarditis. So looking at this, prosthetic valve endocarditis is overall sensitivity is 93%. When you can look at with standard workup, the 100% sensitivity is 83% sensitivity and 25% change in treatment plan based on the finding when you do with CT and you find the extra valvular involvement in these patients. And also for the perivalvular infection, there is good accuracy for that. So again, when you are thinking of more than the standard endocarditis that is not leading to a sequelae, this is like when there is local involvement, there is complication, then CT is going to be helpful for these patients. Now, TAVR endocarditis is also another important aspect that we'll start to see, and it's important that we recognize it early. In 2012, I had in my practice one patient who had a valve implanted, and this is her CT after the valve. She was living in another city, and she started to develop UTIs, one time even admitted to ICU with urosepsis, and everything was reported as okay in the other city. Later on, she was brought in frank pulmonary edema. Transthoracic echo showed a mean gradient of like 45. The patient was so dyspneic, we wanted to get a TE, but she was like gonna require intubation to do it. So we did a quick CT, and now you can see all of these fibrin material in the prosthetic valve. This patient was started on anticoagulation, but she had a PA arrest 12 hours after this CT, and she died. So these patients actually deteriorate very quickly, and remember, there are comorbidities, at least in the early days of TAVR. These are the patients who got TAVR because they are not good surgical candidates, and they had multiple comorbidities, advanced lung disease, and others. And this is a recent data from multiple centers looking at the mortality of TAVR endocarditis. So you can see a very high mortality early on, even in the first few months. And now at 2 years, it's about 2/3 of these patients after endocarditis die. So this is a very important complication that one needs to be aware of and treated aggressively. Unfortunately, many of them are not surgical candidates, so at least the earlier cohorts who got the TAVR because of inadequacy for medical therapy, for surgery. With CT, we can also look at extracardiac involvement. So most of the time we look at the valve, but also during our cuts, we can see the spleen. So this is something that we can also look at. So we can look at splenic infarcts. And if you've done some other studies, you can see brain abscess, you can see against multiple splenic infarcts, renal infarcts. We don't usually go that far, but sometimes we do see some of the upper kidneys in our scans. And sometimes we can see mycotic aortic aneurysms. So CT can help you with that. And finally, before these patients, most of the time they're coming to us because they were planned for surgery, and nobody want to cath these patients who have a vegetation sitting on the aortic valve, and you don't want to shove it down a coronary ostium. So we can look at the coronaries. Now remember, this is a challenging situation because these patients are usually tachycardic. They have valvular complications like acute AI and others, and it is almost a hit and miss. At least most of the time we can clarify the proximal segments, but the distal segments may not be an easy task to do. But we try our best usually with these patients. Now, in some studies looked at those patients where you can see the coronaries in some of these patients, and it does have high negative predictive values. Among patients, these are not all endocarditis. These are like all comers, usually more stable, especially the MS patients and the AS patients. But when you look at the meta-analysis that included 17 studies, nearly 1,100 patients, the overall accuracy for CT is about 93%, specificity is 89%, and AUC of 94%. And many of these patients nowadays are going to surgery based on CT without the requirement of an invasive angiogram for clarifying the anatomy.
Yeah, you should mention just one other thing because the temporal resolution. The temporal resolution of the newer systems allows us to really image people with really heart rates of 80, 90, 100, even up to 110,
Yeah.
120. Remember, with a dual source system, if you have a heart rate of 120 and you're imaging, you really have a heart rate of 60. So you're able to. So if that heart rate is 60, you're able to get pretty much frozen images, especially if you image over a system.
Yeah.
any kind of change, even if you have some variation in your RR intervals, you should still get pretty good.
Yeah. Yeah, but again, there are still some cases that we still, with high heart rate, may not be able to clear. So I just want to set the expectation of everybody right, that you're gonna have some patients where it may not work, but most often, at least, we are able to see the proximal segments and clarify if there is a disease that need to be bypassed at the time of surgery.
And
So
when push goes to shove, we try it. Again,
yeah,
most of the time
we always try it. I mean, I think if the systems we have here have the best temporal resolution available. So if you, and we have all the tricks like imaging and systole and others. So if you are able, if we try our best to be able to see it, I would say our success rate is about 80-90%, but there's still a small percent now. When we started, it was like more about 30-40% success rate. Now with the newer technology, we are moved much higher, but still there is a very small minority that we cannot image. And there is no need to subject these patients to the risk of coronary angiography with the risk of embolization when you have this highly mobile vegetations. So I'm going to quickly move on through MRI. And one of the things about MRI that I see people send many cases often, that they see something on echo highly mobile and they want you to see it by MRI. That is kind of very difficult. Because remember, in MRI, the image is acquired, it's like kind of a summed image over 8 heartbeats, or even if you're using like fast imaging, you're like 6 heartbeats. So if this vegetation or this highly mobile structure is at this point in this beat, at this point in the other beat, at this point in the other beat, it will be averaged out and you may not see it. Now there are, if you are lucky, there are some case reports that you will find out that they've seen some fibroelastomas and some highly mobile vegetations, but these are not usually the norm and it might be difficult to see them. With MRI, you mostly see the complications of endocarditis, so you have an ability to look at the valvular lesions, obviously, and the function with these. If there is an abscess or collection, like you see here, pseudoaneurysm, then you might be able to see them. So if there is a pseudoaneurysm or abscess, you can look in here also and look at some of the valvular lesions and maybe some of the calcifications and mobile structures. And this is, for example, another case of prosthetic endocarditis where you can see some valve dehiscence and there is a abscess collection there. This is the same patient with CT, and this case is courtesy of Dr. Nabi, where you can see that there is some dehiscence of the valve, and this is the same patient where you're looking at the different complications of endocarditis, and you're able to see clean coronaries for this patient who went for surgery, even on the older systems, that you're able to clarify these. Now we're going to move on to things that light up, and with that, it's PET. So PET endocarditis is a relatively very new field, and this has been kind of advocated primarily by the European. There are some leaders in the field who have been pushing it from the European Association of Cardiovascular Imaging. And what you'd like to see is that we're using FDG, which is fluorodeoxyglucose, try to inject it, and now we're trying to image not the myocardium, we're trying to image the neutrophils and the macrophages. So ideally, when I want to inject it, I want it to go inside the cell of the macrophage to the mitochondria and get stuck there, because it doesn't go into glycolysis. So that F18, then we can go ahead and image it. But to be able to do that, remember, the myocardium likes also to take glucose if there is enough insulin. So this is what we do for viability study. So we need to prepare these patients very well for that. What does preparation mean? That they should be fasting for nearly 12 hours. These patients should have low, or I personally prefer no carbohydrate diet as much as possible for more than 24 hours. And then when they come to us, before we inject it, we give them IV heparin if there is no concern, obviously, about brain embolization, because heparin does inhibit glycolysis in some studies. So it does inhibit the myocardium to take the FDG. And then we give them the FDG, wait for about 45 minutes to an hour, and then go ahead and image them. It is very important to inhibit them because you can hear, see, this is the patient with cardiac preparation. This is the patient without cardiac preparation. And what you see here is just a normal uptake of FDG by the heart. So these patients actually are not well prepared, so it might limit your sensitivity and ability to detect the infection. So life could be easy in PET. So this is a patient who has no uptake. So we are clear, we're happy that this patient does not have endocarditis. On the other hand, this is a patient who did light up. So we see a lot of uptake in there, and now we are sure that this patient have endocarditis. The reality is we don't often see these patients like across the two ends. We see them in shades of gray. So sometimes it is highly lighting up, sometimes it is just like around the annulus, around the surgical material. One time you could see it like just one focus in there, or you can see it around the ring. And it's very important to identify which ones are endocarditis and try to correlate it with the anatomy also to find out what exactly is going on at that structure. So if there is an abscess, for example, and dehiscence and collection by echo at that spot and it's lighting up, then I'm sure that I'm getting this is highly suggestive of endocarditis in this patient. And if you have someone like this who clearly by CT has like kind of a collection there, and now it is lighting up, and multiple areas on CT where you have like pseudoaneurysm or abscess-like collections there, and now they are lighting up, then you are sure that these patients have endocarditis.
Can I make one comment about that? Because this is incredibly important. Because especially early post-operatively, you get a lot of fluid collections around grafts and all the rest, and you're not sure, is that infected or is that not infected? Sometimes it's obvious, but a lot of times it's very unpredictable. So this helps tremendously.
Yeah, so there is a caveat I'll talk about in a few more slides in there. So we can also apply it to TAVR. This was actually on the ESC website a few months ago, where you can see here that even TAVR endocarditis, if they have that. So this is kind of nice imaging tool that can be applied. However, one thing I want to leave you with, unfortunately, FDG PET is not for native valve endocarditis. The accuracy of native valve endocarditis with FDG is about 40%. And the negative predictive value is not too high. So if it is negative, doesn't help you. If it light up, then you're okay. You have the diagnosis. But if it does not light up, that does not mean that this is native. And the guidelines actually, it's not very clear. Maybe it has to do something with the surgical prosthetic valve material that has or the size of the vegetation or the type of the inflammatory reaction you develop between prosthetic versus non-prosthetic. But that's even in the European guidelines where most of these are there. So in the European guidelines, FDG PET is a tool that can be used primarily for prosthetic valve endocarditis.
I mean, the beauty of PET, at least if you tell me once we have it, which is very soon, we're looking forward to that, is for any other modality, you see an abnormality, and always the differential is this quiescent, is this infectious, is this a thrombus, is this a post-op normal thing, particularly after major surgeries? So I think this is gonna be very helpful, and I'm less concerned about native valves. I'm much more concerned about hardware.
Yeah, so one thing like, for example, here for native valves, you clearly have a patient with vegetation, but it didn't light up in this patient. And the European guidelines now, they modified their criteria. So for example, for possible or rejected cases, if it is a prosthetic valve, the patient can have a repeat echo or do FDG PET or cardiac CT or imaging for embolic events, while for natives, FDG PET is not in there. The other thing is that when you apply the modified Duke criteria and then you add PET CT to it, the sensitivity of the modified Duke criteria now reaches about 97% compared to surgical, while the specificity drops a little bit but was not statistically significant. I'll show you why it drops in there. Because there are some limitations for PET CT, and this is a place where we are still learning. And the highest learning, there are some false positives, about 15%. I'll show you some of the reasons why it could be. There are some abnormal uptake on these grafts after surgery, and this is relating to the bioglue that they use in surgery. So if the surgeon put a lot of bioglue, then it will light up, and this lasts for longer. And we see it also in CT. It kind of lights up, and you think that it might be contrast or something in there. If there are some prosthetic thrombosis and early after surgery, and this is what the guidelines actually in Europe elected to go more than 3 months. Although some data saying, there are a few studies here and there suggest that if the patient, if you have a negative study after surgery, it's kind of ruled out endocarditis. So I'll show you some of the examples. So one of the things, like for example, in this patient, if they did not have good good preparation, then you may not be able to see the valves very well. The other thing here, for example, this is clear no endocarditis. This is clear endocarditis. What about this one? This one, actually, it was more of the not endocarditis because the amount of uptake or the lighting up or the TBR, tissue background ratio, it was only 2.44. So you need to have, for an aggressive infection, it's not a subtle finding. You need to have a lot of uptake. For example, the other thing, which is the most common question, is the issue of infection versus inflammation. So for example, this is a patient that you look in here, and this is from the literature from a group that has done a lot of work in this field. And they tell you here that this patient has some around the tissue, but there is nothing in terms of anatomy to tell you that there is an abscess or so. And this patient, for example, turned out to have sarcoid, and he light up because it's like sarcoid lighting around the valve. This other patient, actually, you can see how much uptake is in the mediastinum. And this patient, actually, they had used a special glue material. And this glue material that they used in the sternum lights up with FDG for some reason. It causes a lot of local inflammation, and it lights up in there. So these are very important aspects for us to know when we are doing these. The other things we look at are the issue of attenuation correction. Sometimes with attenuation correction, it might be increased. So a lot of people, even though we like to use attenuation correction, for these images, we need to look at both the no correction and the correction. So if it is only present on the attenuation correction, then you might be over-calling it. If it's present on both, then you're probably more confident than it is through infection. Usually with inflammation, it is much less uptake compared to what you see.
What does PET show up in the spleen? Anything?
If there is infection and abscess, yes, we can see it. I mean, if we can cover it.
So related question, in our lab, I mean, how often do you guys report the spleen, looking normal or not looking normal? Because when we see, lesions on typically the aortic valve, and we're making decisions around going to surgery, not going to surgery, native or prosthetic, if it's a small lesion, big lesion, evidence of emboli. But we've argued in the past that if the spleen has an infarct, the lesion is prone to embolize, and that they should go to surgery. But we don't always notice a report on CT about the spleen.
So if it is, first of all, we don't usually cover the entire spleen. So if the spleen is in the imaging plane and we see something on it, it's in the report. But if we don't see it, we don't usually write like there is nothing in the spleen or like the spleen is unremarkable. So because the cardiac CT, we only report incidental findings that are important. So when don't have like the standard negatives for the lung, and if we see something, we report it. And most of the time you get like few cuts on the spleen, not the entire spleen coverage. It depends also based on patient. But maybe for our protocol, like if the suspicion is endocarditis, maybe we can ask them to go down a little bit to the abdomen. And look.
But it is kind of an embolic tiebreaker.
We actually, I had a case a week and a half ago, a huge splenic infarct.
Yeah.
Of course, it was reported out as that, and he had a vegetation on the valve. That's extremely important.
Absolutely.
He really had an embolic event and a splenic.
I've had patients with mechanical valves present with left shoulder pain. And it was a splenic infarct that led to the endocarditis diagnosis.
Yeah, there you go. So I think it is, we can actually report that. We see most of the spleen when we do these studies. So we can actually say the spleen shows no evidence of infarction. That's not an issue. We always say it if it does,
All right, and then finally, when patients get antibiotic therapy, you can start to see that there is some decrease in the FDG uptake among these patients. So if you know that the patient is already on antibiotic therapy, usually it doesn't happen in 24 hours or 48 hours. It does take a few days until it goes, so you don't need to get the FDG PET immediately. But if it is like prolonged on and off medical therapy, incomplete antibiotic therapy, then the patients may have problems with that. And then finally, I want to show you a false positive. So here, I don't know if it's projecting well, you see that there is something in there. And this is suggestive whether there is an uptake with FTG. And the problem with this is all this metal artifact that we're getting in these patients with ICD and others. And with these patients, actually, when you see something like this, you have to confirm it with the no attenuation correction and try also to do some of the other software that limit these artifacts. And just by processing, you don't see it again. And this is purely an artifact. So there are a lot of artifacts that you have to walk around. If you figure it out, you can also look at endocarditis and complications, like if there is a lung infarct that you see in here. If there is also like osteomyelitis or spondylodiscitis, and it was reported nearly in about 15% on some of these series. And also, this is another case of discitis that you see in here. Overall sensitivity of infective endocarditis for prosthetic valves is about 81%, specificity 85%. Again, because of the issue of inflammation, and sometimes we could be missing because of all the other issues, we're not 100%. So we have to still to put it up with the other imaging modalities in there. We can also help with pacemaker infections. So here's like, for example, a pocket infection. Here's could be a lead infection, or it could be like at the lead insertion. So it does help with that. And there have been a meta-analysis looking at these in specific, looking at devices. And with PET, 87% sensitivity, specificity 94%, and overall accuracy about 95%. So it does improve it significantly compared to what we see with other. And finally, I want to show you in LVAD infections. This is a new area that has been kind of led by Vascular Dilsizian from Maryland, where he's looking at these patients. And you can look at multiple sites of infection. So it could be at the exit site, but it also could be at the percutaneous exit, could be at the drive line, so you can see where the infection is. It can be at the pump bucket, which is kind of the worst now. It has to be explanted in these patients. And then it could be just like at the cannula, at the exit cannula. Anything that is on the central infection, it's actually bad in terms of outcomes. You can see here that the mortality is very high among these patients. And one thing, again, we have to look in these patients, despite having a lot of metal, we have to look at the attenuation correction and the non-attenuation correction. Finally, looking at the guidelines, so in the US, there are no specific endocarditis guidelines, mostly in the valvular guidelines, and you can see there is the 2014 guidelines. There is a AHA statement on endocarditis from AHA alone, and then there is the update on 2017, and when you search, for example, the update on 2017 for endocarditis word or PET, it doesn't show up for PET in there. But the European guidelines is kind of the one that has been advocating that, and now with the new modified criteria that they put in there, so obviously your major criteria is positive blood culture. Now with the imaging finding historically has been primarily echo imaging, but now you have, there is an abnormal activity around the prosthetic valve by FDG or radio-labeled SPECT CT, which has lower accuracy, so I'm not gonna go through that. And also, if you have definite paravalvular lesion by cardiac CT, now it is considered an imaging finding and a major criteria, and this modified Duke criteria, and your usual minor criteria for that. So with this, I'm going to stop, and thank you very much.